So, what does it mean to have dense breasts? Breast density is a radiologic finding, however, it reduces sensitivity of mammograms in younger women. This is because of a higher proportion of breast epithelial and stromal elements that are present in younger breasts. Having dense breasts is normal and common and occurs in around 47 to 50% of the population. However, increased breast density can obscure detection of benign masses, or more importantly, of breast cancer. Some factors that affect breast density include patient factors and other extraneous factors. Some patient factors include the age. For example, it's more common in women that are yet less than 50 years old. Menopausal status, the phase of a menstrual cycle. There are studies that show that there's increased density when a woman is in a luteal phase. Some genetic factors, whether or the number of children a woman has. Estrogen use, the use of chemoprevention such as tamoxifen, body habitus, and other extraneous factors such as operator dependence and interpreting breast density on a mammogram. So we use BI-RADS classification as a scale that allows us to identify breast tissue density as being in one of four categories. Category A is almost entirely fatty tissue. Category B is a scattered area of fibroglandular density. Category C is heterogeneously dense, which may obscure small masses. And category D is extremely dense breast tissue, which lowers the sensitivity of mammograms. And BI-RADS categories C and D are what we use when we're referring to dense breast tissue. So how does dense breast tissue affect breast cancer risk? Dense tissue can obscure underlying cancer, and it can decrease the sensitivity of mammograms to be able to detect small lesions. Increased density is an independent risk factor for breast cancer. However, this is not associated with increased mortality from breast cancer. Breast density alone does not determine breast cancer risk, and we calculate a relative risk depending on women's other risk factors for breast cancer, which we'll talk about later. So, primary screening tools for dense tissue include a digital mammogram and digital breast tomosynthesis. Digital mammogram is just a routine two-view, craniocaudal and medial-lateral oblique view. However, it can miss up to 20% of cancers, and the sensitivity is inversely related to the density of breast tissue. So the more dense the breast tissue is, the less sensitive the results of the mammogram will be. The other one is called digital breast tomosynthesis, which is a 3D mammogram and utilizes moving X-ray source and digital detector. It has the potential to be able to reduce false positives in a patient with dense breast tissue. However, it does increase the radiation dose when it's used together with conventional digital mammogram.
How do we calculate our patient's breast cancer risk? We can use the Gale model, the link is shown in the slide, which estimates both the 5-year risk and the lifetime risk. Things to ask the patient about include reproductive history and breast cancer history among their first-degree relatives. However, in certain populations, this model isn't as accurate. It may underestimate the risk for Black women who have received prior biopsies and Hispanic women that are outside of the US. In addition, American natives and Alaskan natives, the data isn't as strong. For BRCA1 and BRCA2 patients, there's an alternative risk tool called CanRisk, and patients who have had prior invasive or in situ breast cancers or patients with prior radiation for Hodgkin's might have an underestimated risk. Now that we've talked about a patient's risk, how do we decide when to order supplemental screening? Breast density in and of itself is not included in risk stratification calculators such as the Gale model we talked about, but rather it should be used in conjunction with the evaluation of other risk factors. So if you have a patient that comes in with greater than 20% lifetime risk and they have dense breast tissues, you should consider supplemental screening, such as with a contrast-enhanced breast MRI. This increases the sensitivity for patients who have high risk of cancer, such as those with greater than 20% lifetime risk, the BRCA1 or BRCA2 mutations, people who have strong family history or have had a prior history of mantle radiation for their Hodgkin's lymphoma. An alternative imaging modality is a whole breast ultrasound. There is an increased detection rate of cancer, however, there's also increased false positive rates. So this is a good alternative for patients who are high risk and cannot tolerate MRI due to claustrophobia, gadolinium contrast allergy, or presence of a cardiac pacemaker. We've talked about high-risk patients. Now what about the other people? Low-risk patients are defined as having less than 15% lifetime risk. American Cancer Society does not recommend screening MRI for these patients. For the patients that fall in between, so intermediate risk, 15 to 20%, American College of Radiology rates supplemental screening as a 5 on a scale of 1 do not recommend to 9 highly recommend. This means a patient or a provider has to have a risk and benefit discussion with the patient about meaning of breast density, level of risk, risk reduction methods, benefits and harms of the breast cancer screening, and insurance coverage. What to counsel the patient on? Dense breast tissue is not abnormal. However, it can make it challenging for the radiologist to identify abnormalities and interpret the exam. Thus, the mammography accuracy is slightly lower. Although screening mammography is not perfect, it is the best study tool we have and is the only imaging tool that confers reduced deaths from breast cancer. If you are the patient and you have dense breasts, consult with provider to discuss breast cancer risk to determine whether additional screening beyond mammography, such as ultrasound or MRI, is recommended.